inaugural program of Glaucoma Without Borders, the Global Perspectives of Unified Vision. I welcome our panelists, Dr. Paroli Chupujani and Dr. Shaumendranath Ghosh. I am Dr. Atish. I am moderating the session. So our first talk will be on ocular surface disease in glaucoma patients by Dr. Tarela Frederick Sarime.
Okay, and good morning all. I will be giving short talk on our experience concerning ocular surface disease among glaucoma patients in Ibadan, sub-Saharan Africa. That have no financial disclosure. We know that ocular surface disease is a multifactorial disorder of the tear film and the ocular surface, and some of its characteristics are that of ocular discomfort, tear film instability, visual disturbance, and ocular surface inflammation. Peculiar thing is that for glaucoma patients, they are the increased risks of having ocular surface disease, either on medication or following surgical intervention, or for those on medications as a result of polytherapy and also long-term use of these medications. Exposure to preservative-containing medications, especially benzalkonium chloride, is also a problem. We know that ocular surface disease being present in glaucoma patients on medication affect their adherence, their quality of life, and their visual function. And developing countries like ours, the majority of the drugs are preservative containing, especially BAC, and preservative-free medications are quite expensive or unavailable. So the study was basically to determine the frequency and the severity of ocular surface disease among our patient cohorts. It was a cross-sectional study at University College Hospital, Ibadan. A total of 122 primary open glaucoma patients were recruited who were at least 40 years of age and on medication for a minimum of 6 months. The main tool that was used to assess ocular surface disease was the ocular surface disease index questionnaire. And out of this patient, the mean age was 59, slight female preponderance, vast majority have good unaided visual acuity. So the prevalence of ocular surface disease among our cohort was 68.9%, and severity, majority of them had mild to moderate ocular surface disease. We know that in terms of symptomatology, stinging, burning, peppery sensation, and redness were common symptoms that this patient present, and the side effects of medication use increased with the number of total drop of medication that was used daily. Topical medications that were also used as compared to the presence of side effect had a linear relationship which was statistically significant. Comparing glaucoma severity and ocular surface disease, we noticed that the more severe the glaucoma, the more likely the presence of ocular surface disease amongst them. So what was the outcome of our study in terms of our discussion? Realized that high prevalence of ocular surface disease was in our cohort, 68.9%. There was a strong association between number of topical medications and glaucoma severity and with that of ocular surface disease. And we know from literature that mechanisms that have been put forward includes back preservative in the medications or other preservatives which have slightly less ocular surface disease effect as compared to back preservative-free medications, reduce gallbladder cell densities, and increase ocular surface inflammation. I want to just conclude by saying that the key findings from our study was the high prevalence of ocular surface disease among glaucoma patient cohort on medication. Thank you.
Thank you so much, Dr. Frederick. Anybody has any questions either from the panelists or from the audience?
I have a question. Do you have generic or branded medications? So, was there any differentiation between the patients who received either of the drugs, and how many of those were on preservative-free medications?
We recruited all patients because more than 90% of our patient cohorts are on preservative-containing medications, and they are mainly benzalkonium chloride. So this study looked at all patients who are on back medications, and generally medications are generics because the branded are a bit more expensive,
All right.
not readily available.
Right.
And just one thing that the more severe that the glaucoma was, you have reported obviously that more OSD prevalence there.
Yes.
But is it necessarily so that the more severe patients graded by whatever visual fields or disc appearance were necessarily on higher medications? Because it doesn't always happen that way. Like even severe glaucoma may sometimes be controlled by single medication. So in that sense, was there any looked into that matter?
In terms of multivariate analysis, we couldn't really tease out what was responsible for that. Thank you.
Thank you for your excellent presentation. So I would like to call our next presenter, Artificial Intelligence Accuracy in Glaucoma Detection and Insight from a Systematic Review, Dr. Astrinada Surino. Dr. Astrinada Surino.
Yeah.
Yeah, maybe he will come late. So the next talk is Managing PACG in Nigerian Patients, Phaco versus Phacotrabeculectomy, Dr. Sadiq Muhammad Abdullahi. Dr. Sadiq
He's
Muhammad.
coming.
Yeah, please. In any case, I'll just call out the name.
We will call up the name.
Thank you. Dr. Ghosh, would you like to ask our presenter anything, or anybody from the audience, or any
Yes,
comments on
I
it?
have a question. First of all, do you select the patient on randomization or just selected the patient for phacoemulsification or phacotrabeculectomy by seeing the clinical pictures? Yes, that's true, because if you see the primary angle closure glaucoma, it's not per se because of the lens fault only. The later stage is a disease of the trabecular meshwork as well. So, if you only go for the cataract extraction, but the trabecular part you are not addressed, then your IOP reduction will not be sufficient. Okay, thank you.
Thank you so much. So next, I would like to call upon Dr. Mohammed Al Himayari. Is he there? Mm. Okay. So next, I would like to call upon Dr. Shams Norman for his topic on managing refractory glaucoma.
A very good morning. My topic is managing refractory glaucoma, and I don't have any financial interest doing this presentation. I want to present my presentation with a case: a 50 years old male, diabetic and hypertension for the 10 years, painful reduction of vision, watering foreign body sensation in the left eye, vision is 660 in the left eye, intraocular pressure is 55 millimeter of mercury with highest medication. History of failed trabeculectomy in the same eye, new vessels over the iris, and patient history of anti-VEGF injection several times. This is the picture. You can see the bullous keratopathy here with raised intraocular pressure. This is the magnified view. And I did the Ahmed valve implantation in this patient. And this is the tube in situ and the good bleb. And this is the picture. And from hand movement and 46 millimeter of mercury, and ultimately visual acuity was 636 and 15 millimeter of mercury after Ahmed valve implantation. So how actually in case of neovascular glaucoma, ultimately the Ahmed valve implantation is my choice. So what are the things we have to be think of? What is bleeding? With very much fibrotic tenuous capsules, sometimes MMC can be used. Adequate space for the valve plate is very much important. Perfect suturing of the valves. A gentle manipulation over the valve because there is the valve system can be damaged. Adequate needle track for the tube, and the adequate tube cut is very much important. And tube must not touch iris or cornea. So refractory glaucoma. So what is refractory glaucoma? Non-responsive to anti-glaucoma, failed trabeculectomy, potential risk of failure. Example like axenfeld Rieger's, iridocorneal endothelial syndrome, neovascular glaucoma, aniridia, Sturge-Weber syndrome, congenital glaucoma, failed trabeculectomy, Efaki or pseudophakic glaucoma, and traumatic glaucoma. And risk factors are multiple surgeries are the risk factor: inflammation, trauma, young age, and secondary glaucoma. Evaluation is very much important, like history, like systemic disease history or trauma history. Slit lamp examination is very much important because we have to find out the iris new vessels or any other secondaries. Details fundus with angiography. Gonioscopy is utmost important. Intraocular pressure, disc field, and OCT has a role. So management. So it depends on the management of the cause actually. The anti-VEGF is very important for the neovascular glaucoma. If need the retinal laser, systemic disease control, hypertension or diabetes, anti-glaucoma medications, especially the beta blocker, carbonic anhydrase inhibitor, and alpha-2 agonist or combination. Filtration surgery with antimetabolites, but usually it fails. Glaucoma drainage device and cyclodestructive procedure. But MIGS has a very less role in managing the refractory glaucoma. This is a case of Sturge-Weber syndrome. I'm giving a Ahmed implant here. So good cautery is very much important because it is a vascular disorder, and conjunctival and intraocular vasculature is more, and might be associated with the choroidal hemangioma. So we have to exclude it. Postoperative hypertony is very much common. Suprachoroidal hemorrhage is also common. We have to take care of that. Postoperative hypema is not uncommon. So to prevent the suprachoroidal hemorrhage and to manage, the sclerostomy can be done. What about the non-valve implant? I do practice with Burwell, the implant, and Wiener glaucoma implant. This is a case of childhood glaucoma where the trabeculectomy and trabeculotomy failure. So scar is the main problem, and tight eyeball due to raised intraocular pressure. So this is the Burwell implant, and the Burwell, we have to insert the Burwell to two arms of the Burwell underneath the two muscles, superior rectus and lateral rectus. So here is the thin sclera is a challenge. So after inserting the tube, I have not used the self-scleral flap. I have used here the tutoplast, or we can use the donor sclera here. And the postoperative hypotony is not very much uncommon in case of childhood such glaucoma, and I did the tube occlusion by the Vicryl. So this is a case of exemplary Leger's anomaly. So I did ADI implant in such case. So fibrosis is a challenge because it's a very, very dangerous refractory glaucoma. In this case, bleeding was a problem, and sometimes AC space is not enough due to peripheral antistanychia. So tube cannot be inserted into the anterior chamber. Sometimes we have to insert the tube behind the iris. We have to take care of the hypotony and also hypema. This is a very new implant, the Wiener glaucoma implant. This is I have started nowadays. This is a case of neovascular glaucoma with 2 times failed trap. It is a non-valve implant. You can see it is smaller than the ADI. It is only 200 millimeter, and there is the muscle hooking is not needed. It is non-valved. It is soft, small, and tube occlusion is enough to reduce the hypotony. The same method. So my observation, postoperative hypotony is not very much common. It's in a very high IOP with advanced cupping, better to avoid ADI or any non-valve. Muscle identification and plate insertion underneath the muscle is a challenge. Muscle injury is not frequent. Heavy fill in case of ADI implant. Displacement is more common in Ahmed because it is, and posterior blade is more common in ADI. In case of thin sclera, it is better to do the scleral patch or tutoplast is a better option. Thank you for inviting me here. Thank you.
Thank you. Thank you so much. Dr. Parul, any comments on that?
Yeah, in your first case, the corneal image was quite. It looked pretty much like as if the patient had taken nitarsodal or ipasodal. It looked less like endothelial decompensation rather than, was the patient on either of the drugs, nitarsodal or ipasodal?
No.
And having said that, if the cornea was compromised, would you have considered doing a phacoemulsification and putting the tube in sulcus rather than putting it in the anterior chamber and running the risk of an endothelial decompensation later?
Actually, that is the case of neovascular glaucoma. So there is a very deep anterior chamber, and you can see the lens is not very much cataractous, and the tube can be inserted very perfectly in the anterior chamber, and tube doesn't touch the lens or in the iris. And that was the case of actually neovascular glaucoma with bullous keratopathy. And after giving the mannitol injection, it has gone, and again it comes back.
Yeah, so that's what, like, doing repeated surgeries in such patients where the cornea is already compromised, uh, uh, doing a single sitting surgery wherein probably you would have done a phacoemulsification, taken care of the cataract, and put the tube in sulcus, runs the
Yes, this is a
risk
good
of,
option.
yes.
This is a
All
good
right.
option.
Thank you.
Doctor, I have a question. Now, how do you select the which patient will be undergoing in a valved surgery or in a non-valve device? And what is your selection criteria, just as general?
Actually, those patients have a very advanced glaucoma, like point 0.9 cupping, and very high intraocular pressure. In such cases, I do prefer the valve implant. But in case of as if I use the non-valve implant, because we have to occlude the suture, occlude the tube, so that post-operative intraocular pressure can be raised more, and it will further damage
Wipe out of the
wipeout. So there will be risk of wipeout in case of non-valve implant, especially earlier valve.
Another one, I just make a comment because you said in a Starr-Weber syndrome. In Starr-Weber syndrome, whatever you want to expect that hypotony never happen, but in
Still there is a possibility.
particularly Starr-Weber syndrome is very dangerous
Very
because
dangerous,
if it is
yes.
a hypotony occurred, you may lose.
Very dangerous, very dangerous.
Okay, that's all. Thank you.
Thank you. Thank you so much. So, next I would like to call on Dr. Paul Healy for his presentation on trabeculotomy tips for successful outcomes. Dr. Healy. Thank you so much, Dr. Haley. Would like just to ask you that, like, do you routinely do a removal of a part of the tenons when you're doing this surgery?
No, I don't. I mean, you know, the conjunctiva and the primary trap, the tenons is relatively elastic. So usually, if we can create a clean dissection, then when I'm bringing the conjunctiva back, rather than letting the tenons retract, which will form a sort of a ring of steel around the bleb, I actually pick up the tenon with my last bite of the dorsal suture and pull it down. If I do that and there is some tenons that's come forward, particularly if the initial dissection was difficult before it's a redo, then I'll trim what's left. But because the tenons will migrate, I've found it more successful to have an even layer of tenons across the whole bleb rather than have an area of exposed conjunctiva with tenons behind it. Because inevitably what happens is the tenon scars down, the bleb area gets more homeostatic pressure increases, you then get avascularity because of the high pressure, and then of course you get a thinning of the conjunctiva at a risk of leak.
Thank you, Dr. Parul.
Yeah. I've been a fan of your surgeries. I've seen them in APO, APGC, and WGC. And with your work in cell biology, it's just wonderful. I had a question. So, the Singapore group has just printed in 2023 that they're using ibuprofen for preventing early bleb failures. So, do you have any experience with that, or do you encounter patients wherein there are high risk of bleb failure? So,
And that the credit for that goes to Tony Maltino, who was actually the father of all ceton implants. Right? He invented the ceton implant in 1976, and in 1979, I think it was, he invented the first anti-fibrosis treatment, which is a combination of, for him, it was diclofenac, colchicine, and prednisone. And the Otago study, which was a cohort study looking at his trabeculectomy patients over 20 or 30 years, showed that that multi-node cocktail was very effective. So yes, I do that. It is, I have to say, the patient I would use a multi-node cocktail in for either a trabeculectomy or a tube is one where you get a very, very strong, intense healing effect. You know, I'm sure you see it in all the time. Intensely red bleb, you know, the eyes very painful, and that combination can settle the eye down very well. For lesser amounts of inflammation, an NSAID by itself works well, or an NSAID combined with a low dose of colchicine. So yes, it's very old-fashioned, but I think it's very effective. The issue is always going to be the patient's GIT system, particularly when you give them an NSAID with a colchicine. And in Australia, we have a lot of stressed patients who have gastrointestinal
Yeah.
problems, so I always start them on a proton pump inhibitor as well. But yes, no, it's certainly recommended.
Dr. Shomendra.
Dr. Helene, very nice presentation. I just wanted to ask you a question that how much concentration of MMC you used, and how do you determine how much time you need?
Okay, so the cell biology for this was done by Professor Jonathan Proston, who trained at Moorfields, was my last registrar and first fellow. Now he's a professor at Sydney University. So what he showed was that there's a dose-response curve for both time and concentration of mitomycin, and it fits actually nicely with actual human use. So below about 1 minute, you get very little effect. The key part of the dose-response curve in terms of timing is between 3 and 5 minutes, and beyond 5 minutes there's not much at all. If you look at concentration, and this is in the laboratory, so this is not in vivo, you get, again, very little effect under about 0.1 milligrams per mil. Between 0.2 and 0.5, you get that maximum increase, and about 0.5, you don't get very much. When I was doing my fellowship, we were using 1 milligram in children, and that's fine for endothelial necrosis, so we're getting ischemic area, so we stopped doing that. So my minimum concentration of mitomycin is 0.4 milligrams per mil. When I then, and 0.3, in 3 minutes for a patient who's not going to scar much. If I have someone who's going to scar a lot more, I'll usually do 4 to 5 minutes. And then for a revision, I'll probably use a maximum of 0.5 milligrams per mil for 5 minutes. And I actually use a technique for my revisions which
has used that technique of transconjunctival, yes. Yes. So do you use doxycycline also for bleb health in any part of post-operative care?
I certainly do if we're looking for frequent with blood lesions. But I think the way to fix those blebs that we worry about is to do some structure to them. And one of the things you can do, which you may not think of when you see an ischemic bleb, very thin, you can see no blood vessels. If you look very closely under high magnification, the vessels are there, the Gauss vessels. So hydrostatic pressure is too high. If you actually do a revision and remove and cut through all that scar tissue and make the bleb much bigger, many of those areas of ischemia disappear. The bleb can become healthy again. So I think if you've got high hydrostatic pressure, thin bleb which is swelling, doxycycline might help, but it's not going to cure the problem. You need a structural change to rehabilitate patients back to normal. And we all experience that.
Yes.
Yeah. Yeah. Thank you. Thank you so much. Thank you so much, sir. Next, I would like to call upon Dr. Kazuhiko Mori for his presentation on gonio surgery with double mirror gonio lens.
Where is it? Okay. Okay. Okay, my name is Dr. Kazuhiko Mori from the Kyoto, Japan, and I'd like to talk about the gonio surgery with a double mirror gonio lens. Okay, so this is the Kyoto and my university, and then here I have the interest of disclosure because ocular instruments made the Mori gonio lens, the double mirror gonio lens, and I'm one of the inventor of that. Okay, so surgical gonio lens or prisms is usually we use a direct type, it's no mirrors, and then but direct type gonio lens has some weak point because you must tilt the patient's head or maybe the microscope. So because of the viewing direction and the instrument directions are the same. So this one is using the Swan-Jacob direct type, and then doing the video doesn't work. Sorry, file doesn't have. Okay, so this somehow strange works. No, maybe it doesn't work. So using the gonio synechial lysis, you must change the patient's direction with a nasal or temporal or upper or lower. So that's the problem with the direct type for using the direct type gonio lens for the gonio synechial lysis. So in that case, what is double mirror gonio lens? So this project was started in the late 1990s, and then double mirror peripheral vitrectomy lens, it's called the Tano lens, was Ocular made it before. And then also there is a Penco made it one time the direct view gonio lens for the viewing system. So this one has a double mirror, so that's why I thought that it should be good for the gonio surgery. So initial prototype was made in the 2000 December, and then I made a paper for the double mirror gonio lens with a dual viewing system for the gonio surgery. So the article was in the AJO, American Journal of Ophthalmology, in the 2007. So this is the Mori gonio lens. Should be works, yeah. So it's on market in the 2008, and then I can rotate the lens, and then whole gonios was viewing was done without tilting the patient's head or the microscope. And after that, there's some different types of the double mirror gonio lens were made with the ocular upright 1.3 times surgical gonio lens in the market on the 2014. And also, Dr. Ike Ahmed made it the ocular Ahmed DVX surgical gonio lens on the market in 2018. So there are three types of the double mirror gonio lens. So we can use the lens for the gonio surgery. So all up internal approach with the mix is intraoperative gonioscopy. So that's why this is a GAT. I usually do the hemi-GAT for the not the whole 360 degrees, but 180 degrees. So cut gonio with a needle and then put the suture into the ceramic canal, and then 7 stroke, and it goes to the direct opposite side. That suture was in there. So after that, they cut the suture and then grabs the suture and then pull from the outside. Then it's a 180 degrees, gonio, gap was done. So this kind of the surgery can use it for only, not only for the adults, but also the pediatric congenital glaucoma. So this patient has a 1-year-old male, and then the anterior segment is no anterior segment abnormality, and the cataract is not there, but a slightly corneal opacity was there, half straight. And then IOP was 18 on the left, right, and then 34 to 45 in the left eye, and then corneal diameter is a little bit too long. So this patient has a congenital glaucoma, and then I did a gonio gap for this patient. So this is a surgical view with the lens gonio. Oops, sorry. And then with monocle lens, and you can check the 360 degrees gonio. But this patient has, when compared to the adults, the children's gonio is no pigment was there, so it's very difficult to detect the trabecular meshwork. But anyway, we can try. So with this same procedure with the adults, and then cut the TM. But there's some problem for this patient because of the children, and then TM is a little bit small compared to the adults. So there's some resistance to put in the suture. So looks like it's in. You see, it's in, but there is some resistance. So it's not in. It's behind the TM. So sometimes they call it, and if you cut the TM too deep, then the suture goes into the posteriorly or backside of the TM, ceramic canal. So first it doesn't go in, so I could go to another position because of my monocle lens, I can cut everywhere. I can approach. So one part is not good, then the other part gets, oops, it's gone. Sorry. And then after that, here. And here I can put the suture in from here. So it's 3 o'clock. And then put the suture in. And then the upper half, 180 degree, was cut. So put the suture directly in, and then it smoothly get in compared to the first one. Oops, not yet. Now it's in. So put the suture in, and then it smoothly get in even in the children's eye. So after that, the same thing, and then the upper half of the TM was cut. So the canal procedure includes the GAT or upper internal canaloplasty is a interoperative assessment of the three-dimensional location of the ceramic canal is crucial because it's cut too deep, then the suture don't go into the ceramic canal. If it's too shallow, and then it's not good for that. So you must see where the TM or the ceramic canal is. So it's too surface or too deep is not good. And then too posteriorly, it goes to another direction. So the instruments or the suture go behind the ceramic canal. Yes, it is. Like I show you the children. So there's a report with a bell. It's a band of the extracanalic limbal lamina. It's a so-called TM shadow. And there's a hard area behind the TM. So if you behind the PM, behind the ceramic canal, so if you cut this bell area, then the suture or the other instrument go into the right, different or wrong direction. So the take-home message is one: it's an intraoperative gonioscopy is getting important because of the popularity of the MIGS. And then keeping the optimized visualization is the key for success in gonio surgery. And then never get lost in the world of prism or the mirror. And also for the canal procedure, assessment of the three-dimensional location of the ceramic canal is crucial. Okay, so I'd like to introduce you, show you this slide because of the next year we will have the World Glaucoma Congress, and then JGS will host us from the Japan Glaucoma Society, and then it will be next year April Kyoto. So please come to the Kyoto. Thank you very much.
Thank you. Thank you, Dr. Mori, for excellent presentation and wonderful surgical videos. Dr. Parul, any comments?
I'd like to know a little bit more about the bell, if you may. Yeah.
Okay, so the bell is like an anterior segmental CT shows that there's a reflection over there, and it's a hard tissue. It's maybe not the cornea, but kind of the squirrel or maybe a little bit hard tissue, and then that's why the OCT has some reflection and there's a shadow over there. So it's and also the histologically it says some packing area. So that's why if you cut the TM too deep, then you can cut. You may cut that bell area. Yeah.
Dr. Shomendra?
Sir, I have a question. What is the advantage of this two mirror lens in comparison to the direct gonio lens, and what are the disadvantages also?
Okay. So the advantage is no need to tilt the microscope or the patient's head, and then disadvantage is that there are two mirrors, so a little bit dark because the light is lost. So you must light up the microscope. Yeah.
Okay. So I think we have finished within time. So thank you everybody for your attendance, and I hope it was a wonderful discussion and it has elucidated a few points for many of our listeners. Thank you everybody. Okay. Can I invite the speakers on the stage for a group photo?